So thank you very much for that introduction. So we're going to be talking about dizziness, which is a very broad term. A couple things goals of the talk. You will learn how the balance system uses both sensory input from the inner ear to maintain balance. You'll be able to describe the function of the vestibular system and common symptoms and causes for damage to the vestibular system, as well as to define specific vestibular disorders and common diagnostic tests and treatments for these conditions. And when we talk about the vestibular system with relation to the ear, we're talking primarily about the inner ear. And so if you look here, so we're talking, if I can get this to show up, here's your semicircular canals, your vestibular cochlear nerve, which is going up towards the brainstem. So we're focusing here on the inner ear. According to the CDC, dizziness is the third most common complaint heard in physician offices. And so as primary care providers, I am sure that you see this a lot. 85% of vertigo and balance dysfunction may be inner ear related. So when I have a patient who comes to me with dizziness, the first thing I want to know is, what do they mean? Because dizziness can mean a lot of different things. So I usually ask them first to describe what they feel like. And then I ask more specific questions. Do they experience room spinning? Is it more of a lightheadedness? Or is it an off-balance or swaying sensation? The quality or type of dizziness, in addition to duration of symptoms, will help me to determine if I think it is coming from the inner ear. In duration, we're talking about, is it a few seconds? Is it a few hours? Or is it lasting days at a time? Is it consistent, constant, or is it intermittent? So when we talk about dizziness, we have to talk about balance. And balance is the body's ability to maintain its center of mass over its base of support. It is achieved by a complex set of sensory motor systems that include sensory input from the vestibular system, vision, as well as proprioception. From the vestibular system specifically, we're receiving sensory information about motion, equilibrium, and spatial orientation. And this is included from inputs from the utricle, saccule, and the 3 semicircular canals, again, which is in the inner ear. The utricle and saccule specifically detect gravity and linear movement, whereas the semicircular canals are detecting rotation. We then have the vestibular nerve, which is part of the vestibular cochlear nerve, or cranial nerve 8, and has 2 vestibular portions, specifically this superior vestibular nerve, which innervates the utricle, the superior, and the lateral semicircular canals, and the inferior vestibular nerve, which innervates the saccule and posterior semicircular canal. We then have our motor output. So as we integrate the sensory information, the brainstem then transmits impulses to the muscles, controlling the eyes, the head, neck, trunk, and legs. And this allows a person to maintain balance and also to maintain clear vision while moving. When we talk about the peripheral vestibular system, there's 3 main reflexes that we talk about. The vestibular ocular reflex is the reflex that coordinates eye and head movement in order for us to keep focus on an object while we're moving. The vestibular colic reflex takes information from the otolithic organs, as well as and again, those are the utricle and saccule, as well as the semicircular canals, and activates the muscles in the neck to keep our head stable while we're moving. And then the vestibular spinal reflex is a reflex that maintains your posture and stabilizes your body to maintain an upright position. And again, this just summarizes sensory input, integrating that, our motor output, and then giving us our balance. So when I see a patient with a vestibular disorder, there's a wide variety of symptoms that I can see. Patients will often complain of imbalance or unsteadiness, vertigo, which again is specifically referring to a spinning sensation, dizziness, blurred or bouncing vision. Commonly they'll have nausea, headaches. They can have associated hearing changes and tinnitus, as well as problems with coordination, thinking, and memory. So I will sometimes have patients who tell me that they feel kind of like almost an out-of-body or surreal sensation that is associated with their dizziness. The list of vestibular disorders is quite extensive. This includes an acoustic neuroma, which is a benign tumor of the inner ear, autoimmune inner ear disease, benign paroxysmal positional vertigo, or BPPV, cervicogenic dizziness, cholesteatoma, which is a skin growth in the inner ear, enlarged vestibular aqueduct, which is a congenital condition, labyrinthitis or vestibular neuritis, maldebarkment syndrome, which you often see on patients who have been on cruise ships and when they get off experience these symptoms. Meniere's disease, migraine-associated vertigo, otitis media, otosclerosis, ototoxicity from medications, perilymphatic fistula, and superior canal dehiscence. So I'm going to focus a little bit more on BPPV, which is probably the most common cause of vertigo. It affects up to 50% of people over the age of 70. And it results from otoconia, or what we call crystals, that become dislodged from the utricle and then collect within one or more of the semicircular canals. And I like to explain, when I explain this to patients, I say, well, we have these canals that sense and tell us that we're turning, but when these crystals get out of place, it's telling us when we're turning when we're not. And that seems to click with them. Earlier this year, the American Academy of Otolaryngology had neck surgery published an update to their clinical practice guideline specifically about BPPV. So a couple highlights. Clinicians should diagnose posterior semicircular canal BPPV when a patient presents with vertigo with associated torsional upbeating nystagmus. So what you're going to see is kind of like you'll see the nystagmus where they're rotating, and that's what we're talking about with torsional. And it is brought on by the Dix-Hall-Pike maneuver, and specifically, this is where you're taking a patient from an upright position, laying them supine, rotating their head towards the affected ear, and then bringing on the symptoms. And it can come, there's oftentimes a slight delay, meaning you put them in this position and it can be up to 10 to 30 seconds before they all of a sudden develop these really severe brisk response. If the patient has a history compatible with BPPV and the Dix-Hall-Pike exhibits rather than torsional, but more of a horizontal or no nystagmus, then you would perform a supine roll test, or what we call a barbecue roll, where you're rolling them back and forth, and that's more consistent with a lateral semicircular canal vertigo. That's often harder to diagnose. Patients can sometimes have both. They can sometimes convert. The posterior canal is much more common. Lateral canal is less common and harder to treat. If the patient has a history and exam consistent with positional vertigo, the guidelines indicate that we should not obtain radiographic imaging or order vestibular testing if they have no additional signs or symptoms. So if it's clear, they come in, they say, oh, I roll over in bed, I get this acute spinning, it lasts 15 seconds, it goes away, and then you do their Dix-Hall-Pike in the office and you are able to reproduce the symptoms, then you do not need to do further testing, you send them for treatment. A lot of times I will send further testing if they have other features like, okay, yeah, it goes away, but then I still feel off, and I'm getting these headaches, and and additional symptoms. Then you start probing further. In addition, clinicians should not routinely treat patients with BPPV with vestibular suppressant medications such as antihistamines, so that includes things like meclizine, and benzodiazepines such as Ativan or Valium. The problem with these medications is while they help symptoms acutely, they suppress the patient's ability to overcome the insult. And so we're trying to get these crystals back into place. We're trying to treat the symptoms. And what these do is they just suppress that ability. Clinicians should treat or refer to someone who can with posterior canal BPPV with canal repositioning procedures such as the Epley maneuver. And again, they should differentiate or send to someone who can differentiate BPPV from other causes of imbalance, dizziness, and vertigo. in addition, if you have a patient who you've sent for treatment, let's say they've gone through a course of vestibular therapy and they're still symptomatic, then we need to look to see if there's other underlying peripheral or central disorders. And so then, this is where you're looking at diagnostic testing. And so I'm going to turn this part over to our audiologist, Dr. Howard, and she's going to go over a little bit more about what we do when we do diagnostic testing on our dizzy patients.
So my name is Natacia, as Dr. Mackechnie mentioned. I'm one of the audiologists at Valley ENT that specializes in the diagnostic testing for vestibular disorders. Listed here are some of the diagnostic testing that we do and that are essential. First, we start out with a hearing test. They are important because the inner ear houses the hearing organ and the balance organs. Those two organs function separately. However, in certain diseases such as Meniere's disease and certain pathologies such as labyrinthitis, both of those organs can be affected. Otoacoustic emissions, they provide the information about the function of the outer hair cells. You need to have a mild hearing loss or better for those to be present. However, there's been some research that links the early stages of Meniere's disease to absent OAEs while they still have a normal hearing. So it's essential for, it can be good for diagnosing that. ABR, auditory brainstem response, is looking at the integrity of the auditory nerve. So it's looking for any masses, lesions, or tumors on that nerve. Electrocochleography is an evoked potential. It measures the amplitude ratio from the summating potentials that are generated from the outer hair cells and the action potential of the cranial nerve 8. It's in search for Meniere's disease. Vestibular evoked myogenic potentials, those are looking at the saccule and the utricle and the vestibular portion of the nerve that supplies those organs, and it's a good test for superior canal dehiscence. We have the video nystagography, the VNG, that's the gold standard hallmark testing for balance impaired patients. It consists of 3 parts. The first part is the ocular motors. That's essentially making sure that the eyes are connected to the brain the way that they need to be, so I can use the patient's eyes as part of my interpretation for the peripheral part of the testing. It also gives us a good input on any essential, a good screener for any central related pathologies. The second part is the positionals. That's primarily looking for BPPV, benign proximal positional vertigo. And the last part is the caloric irrigations. That's where the inner ear is irrigated or introduced to warm and then cool air. That air excites the system, the vestibular system, and actually produces nystagmus. We look at the direction that nystagmus is beating and the degree per second that is happening, and everything should happen relatively symmetrical, meaning that both of the inner ears are giving equal signals to the brain, and one's not functioning too much or not enough. Rotational chair testing, it complements the caloric irrigations, again looking for the symmetry between the 2 vestibular systems. However, it tests higher frequencies, quicker head movements, and at greater sensitivity. The video head impulse test, again, complements the caloric irrigations and rotational chair testing. However, it starts to incorporate the different canals. The first 2 are limited to the horizontal canal, where the V-hit stimulates the anterior and the posterior canal. Computerized dynamic posturography. It's a platform that's used to sway reference the 3 sensory inputs for balance, so our vestibular system, vision, and proprioception. It obtains objective measurements for diagnostic purposes and for treatment purposes. It's also a good test to start to look for malingerers. And then in some cases we have imaging studies. However, these are ordered and completed elsewhere, but it can give us some good information on the structural side of things versus the functional, is what we see with those tests. So this slide here illustrates some of the data that you would obtain from a VNG test. First and foremost, I always comment on how well the patient tolerated the testing. So for example, certain parts of the test, a patient's going to not do as well depending on the pathology. So for our migraine-associated vertigo patients, they don't do well with caloric irrigations. They get very symptomatic and almost near emesis during that part. So it gives a good insight onto the diagnostics that we're looking for. Gaze, pursuit, saccades, OPK, those first 2 tests there, that's part of the ocular motor testing. The next 2, dictal pike, and the positional testing, again, that's more looking for the BPPV. And then the last part is the caloric irrigations, where the ears are being stimulated with the air, the different temperatures of air. So in this example, the patient, she tolerated the testing well. She presented with a right beating static positional nystagmus, a right beating spontaneous nystagmus, and a clinically significant left unilateral weakness. So when we combined all those findings, that's suggestive of indicative of an uncompensated left vestibular hypofunction. So what are some treatments for vestibular disorders? We have cannula 3 positioning maneuvers. That treats BPPV. The success rate for that is very high, around 80 to 90% of the time a patient could be treated with the first maneuver. However, the thing with BPPV is essentially those otoconia has 6 different places to go into. They can go into 3 on each side. So it's important to get some diagnostic testing to determine where those otoconia are dislodged at, and then that depicts on what type of treatment goes along with it. Home-based exercises, they're assigned on an individual basis to help continue vestibular rehabilitation therapy at home. So vestibular rehabilitation therapy, that is physical therapy for vestibular disorders. It retrains the brain to recognize and process signals from the vestibular system. It's most effective when it's practiced regularly. So usually we have our patients go 2 to 3 times a week for 5 to 6 weeks at a time. We have dietary adjustments. That's especially true for our Meniere's disease patients. Essentially, Meniere's disease is when the inner ear retains too much sodium, so we have those patients back off on their sodium intake. It also stands true for our migraine-associated vertigo patients. Dizziness is presenting as their aura, so we need to find their trigger foods or drinks that are causing that and have them back off on that as well. Therapy and counseling. So vestibular disorders are invincible and unpredictable. So they often can cause anxiety and depression. So counseling can help these patients cope with that. Medication, not a whole lot of medications out there that are going to treat a vestibular disorder, as Dr. Mackechnie mentioned. However, the most medications more so like just mask the symptoms or reduce the function of the vestibular system so the patient's not aware of them. But sometimes it can be helpful to use medications just to help the patient control the symptoms, accelerate compensation, or even diminish any psychological impacts of the vestibular disorder. So such medications would be like anti-nausea or anti-anxiety. Surgery, there's not a lot of surgeries that are going to treat vestibular disorders, however, in a few, such as perilimb fistula and superior canal dehiscence. And then we have alternative therapies, such as like Tai Chi, acupuncture, yoga, meditation, and even Wii gaming to keep that patient going and good. Alrighty, I'm going to turn it back over to Dr. Mackechnie. She's going to talk to you about a patient that her and I encountered.
And I'm just going to go back for 1 second, just a couple comments. One of the challenges with our dizzy patients is getting them to sort of buy into their diagnosis. Sometimes you tell a patient that they have migraines, and they say, well, I don't have headaches, or they don't want to accept that they have migraines. And migraine-associated dizziness is a very real thing, and a lot of times, that's where the testing is helpful too, because you have objective testing that can reinforce that. And the other thing, and I think Dr. Howard was, stressed, and I agree with, is the counseling, aspect. And a patient has to accept their diagnosis to be able to be compliant with treatment. And a lot of these, with our migraine patients, with our Meniere's patients, starting with things like dietary adjustments, supplements, things that they can see, okay, I'm not committing myself to a lifetime of medication. It can make very real differences. I remember I had a patient who I diagnosed with migraine-associated dizziness, and I went over, dietary triggers, and she eliminated yogurt, and she used to eat a yogurt at least once a day. She cut that out, and she feels so much better. And then she's not, and so it's very interesting sometimes what can be the triggers. So, case example. So this is a 78-year-old female who presented to our office with a complaint of dizziness. She describes as an off-balance sensation as well as a veering off to her left side. So she said when she would walk, she felt like she was falling to her left side. She also reported associated left-sided oral fullness and hearing loss. She denied any otalgia, tinnitus, or history of noise exposure. So an initial exam, we always start with the physical exam. So on otoscopy, ears looked normal. She had intact TMs. There was no fluid in the middle ear. On our initial visit, we will do an audiogram in tympanometry. She had type A tympanometry, so her eardrums are moving normally. There's no retraction or negative pressure. Her hearing test demonstrated a mild to moderate sensory neural loss in the right and a mild to moderately severe sensory neural loss in the left ear. What really struck me, though, was in addition to that, we will test the patient's understanding as part of their hearing test. In the right, she understood 100% of the words. In the left, she only understood 48%. And so that's a significant asymmetry. So what I did with that, in combination with that, in addition to her dizziness symptoms, I set her up with Dr. Howard for further testing. And as part of that, she had an ECOG looking for Meniere's disease, because that can be an asymmetric hearing loss, and that was normal. She then did an ABR, which showed normal function on the right, but a delayed transmission of signal in the left ear. And then her V&G, which actually the report that she went through earlier was from this patient, showed an uncompensated left hypofunction. So we know she has a weakness in that left ear, but in combination, because of the asymmetric hearing loss as well as the abnormal ABR, I sent her for imaging. So we need to look at what's going on with that cochlear vestibular nerve. And so she underwent an MRI with and without contrast, and specifically look with what we call an IAC protocol. So this is looking at fine cuts through the internal auditory canal. And it's sort of hard to see on this. I tried to find a best image, but we're looking. So here is the internal auditory canal on both sides. And on her left side, I don't know if you can appreciate, it's a little bit brighter here. And what this is and what she ended up having was an 8 millimeter intracanalicular, meaning in the internal auditory canal, acoustic neuroma. And so I talked to her, I brought her back in, we went over these results, and it explains, I think, that both the vestibular weakness that she's having as well as the hearing loss. And with this condition, she's 78, so we kind of talked about options. We talked about observation with serial MRIs to monitor for growth, talked about radiation, surgery. At this point, we're watching her. She's going to get another MRI in about 6 months. And then I sent her for vestibular therapy to help with her balance, because that was her big complaint. And she, so far, is doing well. And that's it. Oh, hold on.
Slide you mentioned how methylene suppresses our body's natural tendencies. So we frequently prescribe it. So would you recommend to do those positional changes first, or doing like a small, short trial of it?
So if you have a patient who has a consistent, if you're able to do a Dix-Hall Pike and you feel comfortable doing an Epley maneuver in the office, when they come in and say, okay, this is definitely consistent with positional vertigo, then I try to hold off on doing the meclizine. Sometimes if patients are so dizzy they can't even tolerate a Dix-Hall Pike or an Epley maneuver, then in the acute setting, I think it's reasonable. But I try to get patients to wean off of it. So if they're taking it 3 times a day, I say, why don't you try to cut it back to once or twice a day and have them kind of wean off it as symptoms start to improve. Hey, oh, okay. Candy has. Oh, I think she said she had the same question.
Would you recommend hearing tests before sending them to vestibular therapy first?
If they have a clear diagnosis exam consistent with positional vertigo, I think, and they're not having any other complaints. So again, that gets back to that. Okay, are they having any additional symptoms? If they're not having any other ear complaints, I think it's reasonable to send them, to therapy first. But certainly if they're not getting better, or if they're having other symptoms, So BPPV patients should not complain of hearing loss and tinnitus and, other ear symptoms.